We do have a full schedule today for our presenters. So I'll go ahead and get started as people keep kind of joining the call. We have a few intro slides and then we will get started with the main presentations. So again, my name is Laura Burnham. I'm one of the project directors with CHEER, and I am very proud to be presenting our webinar today on frontline research on human milk and lactation during the COVID-19 crisis. So before we get started with today's webinars, I just want to let you know a little bit about our upcoming webinars. The next webinar we have in this series is on October 14th, and it's Baby Friendly USA is going to discuss COVID-19 updates. And we're going to have presentations from Trish McEnroe, the CEO of Baby Friendly USA, and then Tammy Titus, who's the clinical director there. So that should be a great webinar. And then the next two webinars in the series are on October 21st. We'll be presenting on CHAMPS COVID-19 Survey 2 results. So we've surveyed all of our hospitals in Mississippi about their practices during the coronavirus. We'll be presenting those results. And then we'll also be talking about the next steps for the CHAMPS project in Mississippi. And on November 11th, we'll be covering some nursing experiences during the pandemic and beyond, mostly in Mississippi. So tune in for those two webinars a little bit later. So today we will be presenting again on human milk and lactation during the COVID-19 crisis. Our first presenter is Dr. Lars Bode. He will be presenting on breast milk in the time of contagion. Dr. Bode is a professor of pediatrics at the University of California in San Diego. He's a director of the Larsson-Rosenquist Foundation Mother Milk Infant Research, a Center of Research Excellence, and past president of the International Society for Research in Human Milk and Lactation. After Dr. Bode presents, we will hear a presentation from Dr. Geddes called The Health and Wellbeing of Breastfeeding Women Across Australia and New Zealand During the COVID-19 Pandemic. Dr. Geddes is Professor of Human Lactation, a Senior Principal Research Fellow, Faculty of Science School of Molecular Sciences in the University of Western Australia. And because Dr. Geddes is from Australia, her presentation is recorded because I think it's about 1 a.m. her time. So without further ado, I'm going to turn things over to Dr. Bode so we can begin his presentation.
Thank you, Laura, and thanks for inviting me to present some of the data that we collected over the last 6 months, specifically on SARS-CoV-2 and COVID-19. Great. So before I start, a quick slide on disclosures, where most of our funding is coming from. This is independent of the work that I'm going to present today, but most of our funding is coming from the NIH, the Gates Foundation, the Larsson-Rosenquist Foundation, and I do get travel reimbursements and honoraria from different societies, foundations, company to speak at events like these. Okay, I'm preaching to the choir here, but I think it's very important to understand that there is quite a bit of work that has been done before this pandemic hit. And all that work shows how important human milk is. So the power of human milk is really something I try to hit home here, the first 2-3 slides. And I know you know that much better than anyone else, but I think it's important to start with that. So taking this sentence from the Lancet Breastfeeding series, that the death of 823,000 children and 20,000 mothers each year could be averted through universal breastfeeding, along with the economic savings of $300 billion, is something that we are trying to understand how this works on a molecular level. And just to give you a few examples, still every single day we lose about 2,200 infants and children under the age of 5 to diarrheal disease. And we know, on the other hand, that children who are breastfed have substantially lower risk of suffering and dying from infectious diseases, including respiratory infections. And I highlight this here on purpose. And the question for us is, how does this really work? What is in human milk that makes it so powerful to save lives? At the same time, it's not just the immediate benefits, it's long-term benefits as well. We know that infants that are breastfed have lower overweight and obesity risk, lower diabetes risk, higher IQs, earning potential, and many, many other benefits for life. But we don't know exactly is how this actually works. And last but not least, there's benefits for moms as well. We know that moms that breastfeed, and the longer they breastfeed, they are at lower risk for diabetes, lower risk for cardiovascular disease, and a lower risk for breast and ovarian cancer. And once again, we don't exactly know how this works. And shortly before the pandemic hit, literally a week before the pandemic hit, we asked, this is an article that we wrote in the magazine Science here, we asked for a timely investment in better understanding the mother, breast milk, infant triad. So we literally called for these timely investments in this paper a week before the pandemic was called. And so this is an intro that, of course, you all know, but I think this is very important to keep in mind, that we know about the power of human milk. At the same time, when a pandemic strikes like this, what we don't know is breast milk safe? I think that's the very first question that we need to answer. And we need to answer that immediately. And you see all the consequences that come out when we don't answer this question immediately, because the uncertainty certainly led to many people, and Donna is going to talk about that later, to stop breastfeeding. And so why do we talk about human milk in times of a pandemic? First is the safety issue. Is the virus present in human milk and can potentially be handed over to the infant and contaminate the infant? And can the baby get infected through breastfeeding? And that is very important because we need to guide and support parents and healthcare providers about the safety of human milk. So background to when we came into this field, there were several published studies that reported the occasional presence of SARS-CoV-2 viral RNA in breast milk of infected women. And we published this here in a review article that came out in Maternal and Child Nutrition recently, where we listed all the data that was available until then for the different coronaviruses and for SARS-CoV-2 in particular. Here's one of those studies that came out. This is a paper that was published in The Lancet from a German group in Ulm. Very well done. They report on 2 different moms and 2 different infants, moms co-housed together at delivery, or shortly after delivery. And you see, they investigated moms and infants together, but also looked specifically when milk samples, represented here by the little bottles, tested positive for SARS-CoV-2 mRNA. And indeed, mother 2 here had several samples, sequential samples, that tested positive for the virus. And of course, that raises the big alarm bells. Is that possible that this infant actually gets infected now through breast milk? And you see that the infant indeed got infected down here, but that doesn't mean that the infection took place through breast milk. Okay, so at this point, we had several knowledge gaps. How frequent is this actually? This was 1 in 2 moms in this one study that I just highlighted. How frequent does viral RNA actually occur in breast milk? And does the presence of viral RNA represent active virus that can replicate and cause disease? So we got together with our team here in San Diego and our collaborators up in Los Angeles at UCLA. And we're in a very fortunate position that we have a human milk biorepository that had been collecting milk samples throughout North America for about 3 years already. So when the pandemic hit, we had samples from before the pandemic, but also throughout the pandemic, where moms would send in samples, and it turned out that they later tested positive. So that the biorepository is led by Dr. Christina Chambers at UC San Diego down here, and together with Carrie Bertrand. And we then teamed up with UCLA Health, where Grace Aldrovandi is working, and we had already worked with her on HIV and human milk oligosaccharides in the past and published multiple papers on that. And they happen to have assays ready to go and be validated for human milk. And I want to make this very clear that you can't just take an individual assay that's used for blood or for saliva or whatever it is. You need to validate these assays for human milk. So it's very important that we do this right. Okay, then we immediately got emergency funding from the Family Larsson-Rosenquist Foundation to do some of this work, because you can imagine this work is not cheap. We also got a personal donation out of our community here from someone who had already invested money in our milk bank and immediately came to our help and supported us. We also received supplies from Medilla and guidance from the Mother's Milk Bank Association, especially the ones in Austin, Texas. Okay, so to the first knowledge gap, how frequent does viral RNA occur in breast milk? In this slide, and this is published now in JAMA as a research letter, we had milk samples from 18 different moms, and you see those different participants over in the y-axis where it says participant number, and we had multiple sample per participant, so you see that on the x-axis, and every block that we have here is a milk sample that we had available. This minus 140 means that it was 140 days before the time that the woman tested positive. Whenever you see a white dot, that is when the samples were collected during a time when mom was asymptomatic. And the black dots is when the person was actually symptomatic. Right, so we have a whole variety here of samples that were collected before the positive test. There were samples after the positive test. There were samples that were collected when mom was asymptomatic, and there were samples that were collected when mom was symptomatic. Then we tested all of these samples, 64 in total for this publication. We now have about 200 samples collected, and tested that by RT-PCR, so that is testing for mRNA fragments of that virus. And we found one sample that tested positive in this participant number 8, and it was the first sample that was collected when this person was actually symptomatic and before a positive test. So that happens quite often. A person is symptomatic, develops and doesn't get tested right away, right? So this person was probably already positive and developed symptoms, and then went eventually to the doctor and got a test and tested positive. So that's 1 out of 64, or 1 mom out of 18 participants. Now, this is all RNA. If we take a closer look at how this actually looks like on a molecular level, what are we testing there actually? And I think that is very important to keep in mind. So if we take a closer look at how these viruses look like, if you cut this open, you see outside there's a lot of these spike proteins, and then there's this envelope, and in the middle here, there is RNA. And what we test specifically with the RT-PCR is fragments of these RNAs, right? So RT-qPCR measures RNA fragments, but that does not mean we're testing for active virus. So that is the next question that we needed to address. Does the presence of viral RNA actually represent active virus that can replicate and cause disease? And to show you this in another animation, what does it actually mean? So if you have a virus that goes in, and this is an example from another virus, but it works just as well. The virus goes into the epithelial cell and eventually multiplies in the cell and comes back out. And then it really infects the person, and it's like this multiplying event of viruses that now are in the airway and go through the entire body. So we wanted to mimic this somehow in the lab, and this is not trivial. We're working with a highly contagious virus, so we need to do this under BSL-3 conditions. And the way we do that is we take epithelial cells to mimic the epithelial cells in the airway, then take the cultured virus, and this is SARS-CoV-2 virus, add that to the epithelial cells, wait 4 days, and then measure whether that virus that we just added is actually replicating, so multiplying in tissue culture. And we can then measure that afterwards by seeing if it actually destroys the cells, which it does if it replicates, and measure the amount of viral RNA that now pops out. So you add a certain amount of viral RNA, and if it is replication competent, then your RNA will actually multiply several times. So that means that the virus was able to replicate. Okay, now this is an assay that was established before, but we needed to establish this for and validate this for human milk as well. So what we did is we took human milk that we had already collected and was in the freezer from before the pandemic. So this was from 2017. We then take the virus, add that to the milk, add the milk to the cells, wait 4 days, and see if there is replication. So this is to validate an assay if a virus was in human milk. If there is indeed replication competent virus, can we measure that in tissue culture? And the answer is yes. So we see that the cells get destroyed, and we see that the virus replicates. So the assay works. Now what we do is we test this in our actual samples that we collected during the pandemic, including the sample that tested positive for viral RNA. So we take that milk, these milk samples, add that to the tissue culture, wait 4 days and see what happens. Evaluate the cells and measure the RNA. And the result here is that none of these milk samples, none of the 64 milk samples that we had collected at this point, including the one that had tested positive for RNA, showed any sign of replication competent virus. So there was no virus measured afterwards. So the presence of viral RNA alone is not the same as the presence of replication competent virus. Just because we measure a fragment of the virus doesn't mean that there's an intact virus in milk that can cause disease. Okay, in addition to that, we also tested, is it possible that if the virus ever gets into milk, for example, through human donor milk processing, would Holder pasteurization inactivate it? So here what we did, again, we took SARS-CoV-2, added it to human milk from 2017, then used Holder pasteurization to treat the milk, added the milk to the cells, and once again, after 4 days, we did not find any replication competent virus in the samples. So in other words, Holder pasteurization inactivates SARS-CoV-2 in breast milk should it ever get in there. So even if breast milk was contaminated with SARS-CoV-2 during pumping and handling, Holder pasteurization, which is commonly used by human milk banks, inactivates the virus in contaminated breast milk. So summary of this short study is that the presence of SARS-CoV-2 RNA in breast milk of infected women is extremely rare. We found it in 1 out of 18 women published in this paper, and 1 out of 64 samples altogether from these 18 women. We've now recruited and analyzed about 50 women and 200 different milk samples, or a little over 200 different milk samples, and the stats look about the same. And very important, the presence of viral RNA is not the same as presence of active virus. And last but not least, the Holder pasteurization inactivates the virus should breast milk ever get contaminated. So transmission of SARS-CoV-2 from mother to infant through breast milk is highly unlikely based on the data that we collected, and others have confirmed this in the meantime. Now, on the other hand, now that we established safety, which is absolutely key, now, is there anything in human milk that is actually having antiviral activities? So are there components in human milk that can stop the virus? For example, antibodies. So mom gets exposed, has the virus, makes antibodies, they show up in the blood. Are they transferred now into the milk and potentially provide protection to the infant as well? We study a lot oligosaccharides in my lab, and we know that some of them have antiviral activity for other viruses. Is it possible that oligosaccharides also have antiviral activity against SARS-CoV-2? And then there's many other components in human milk, including antimicrobial peptides and many other things that could potentially have antiviral activity. And again, that is highly important if we want to give actual data to guide and support parents and healthcare providers to show that human milk is not only safe, but it actually provides a huge benefit that we already know for many other things, but also specifically in the context of COVID-19. And last but not least, is it possible to then take some of those components that we find in human milk to be efficient, synthesize them outside of human milk? I'm not saying that we want to now take human milk and give it to everyone that has COVID-19, but can we synthesize some of those components based on the knowledge that we just generated and use that as novel antiviral components against COVID-19 for people of all ages to really stop this pandemic and highlight really the power of human milk and human milk components as we use them in a different context in adults, for example. Okay, what does the success look like? What does success look like? We want parents to be confident to breastfeed. And at the very beginning of the pandemic, and again, Donna Geddes will talk about this, and still, there is a lot of uncertainty about the safety of human milk. And we need actual data to show and guide the health organizations to say, look, we have the data, human milk is safe, people need to continue breastfeeding. We want healthcare providers to make recommendations based on evidence, based on science, not based on fear, not based on dogma, but on actual data. And ideally, we would like to get novel and safe antiviral components to prevent and treat COVID-19 in all age groups. So really learn from the power of human milk and develop new therapeutics that we can use in the fight against this virus. And last but certainly not least, I think what this pandemic really has shown us is that we are not ready when a pandemic like this strikes. That is true for so many different things in our society, but certainly also for the breastfeeding context. We can always say, breast is best and let's continue breastfeeding, but we need to evaluate the safety first. Otherwise, if there is ever a virus or ever a pathogen that gets into human milk and does indeed transmit to infants, we need to know that. And we need to know that based on data. Okay, so I'm coming back to this statement, and I add to that we have to evaluate the risk of SARS-CoV-2 transmission through breast milk, but we already know the risk associated with not breastfeeding. So please always keep that in mind, that yes, we can push breastfeeding because we know the risks that are associated with not breastfeeding, but at the same time, we need to make sure that breast milk is safe, and we need to make sure that that's actually based on data. Like I mentioned, I think there's great opportunities for people of all ages, and there is an opportunity to harness the power of human milk to discover new antiviral components that potentially help us in this pandemic and maybe in other pandemics as well. And I'll leave you with that and take questions if there are any.
Thank you, Dr. Bode.
I immediately have a question, Lars. That was a wonderful thank you. No, my question is, so Lars, are you doing that next round of research? Like, is that on your list to do?
Yeah, so we continue to work on the safety issues. So the frequency of how many samples we find with positive RNA sample is ongoing. Like I mentioned, we have about 50 women or 75 women right now recruited and analyzed about 200 milk samples. And again, the stats look very similar, and we have not identified a single sample yet where we find replication competent virus. So it's very confirming. At the same time, yes, we do work on antibodies, we work on oligosaccharides, and we have some very interesting data on the oligosaccharides that we're confirming this week that actually show antiviral activity that is quite strong.
Great, thank you. I thought you'd be doing any other questions? Sorry, go ahead, Laura.
Oh, I was just going to ask, yeah, the same question as you, Anne. So we have, if you have a question, you can unmute yourself and ask your question directly to Dr. Bode, or if you feel more comfortable or you're not able to unmute yourself, you can enter your question right in the chat box. And I actually have a question for the group too, for those people who are listening to the webinar and who are working directly with mothers. I'm just wondering kind of what they're hearing moms say about COVID and breast milk. If you're hearing moms that are worried and not wanting to give their babies breast milk, or if they think that it's it's something great that they can give their babies during this pandemic time. What are you hearing from mothers? Here we have something in the chat. So this is from Elisa Fern. So I'm a CLC and we're primarily with young moms. There are a lot of providers discouraging my clients to breastfeed out of fear of the unknown. What would you recommend for us non-medical professionals to say or do to support moms wanting to breastfeed? A great question.
I think a great question, and certainly it doesn't help to point them to the publication research letter in a scientific journal, which is not written for the lay audience. We really tried to translate this in layman's terms, and we give key points that I'm happy to share with you that are in lay language. So there have been a few articles that have been written in lay magazines, newspapers, maybe point them to that, where they really highlighted that research shows that breast milk is safe. Keep the hygiene measurements, wash your hands, use a mask when you breastfeed. So the route of contamination, of course, is air. That's the only thing I can think of right now. The data clearly shows that there is no risk of contamination through milk itself.
Lars, has the stuff that you've published in the academic press, have you had any specific like popular media sites or newspapers and channels pick that up that we could refer people to? Because I always know your work is so solid that it would be, because the media comes up with all sorts of stuff all the time, but it would be great if we could say, okay, Dr. Bode has presented this stuff and done this work, and this is where it is accessible in the lay media.
Yeah, so Reuters picked this up. New York Times had an article about that. Several other news outlets picked it up as well. We just had a local ABC interview here, so I can point you to that if you like.
Great. And we can make that available on our website and through our media channels for our audiences as well. Okay, that's wonderful. Thank you.
Great. And we have, I see, so 2 other questions. I think I'm going to skip down. I see Dr. Feldman-Winter has a question, but we have a question from someone else that's really similar to the last one, kind of an additional comment. Just saying, thank you, Dr. Bode. I'm an IBCLC that works at a birth hospital in New York. Thankfully, majority of my mothers want to give their babies breast milk because they understand the basics of immunity in breast milk. But I definitely have to actively fight providers that are not supportive, as stated similarly above. And I guess, Dr. Bode, is there something, do you think these, like the CLCs and the IBCLCs, could do something, or is there a great article they could share with the providers that are of the women that they serve, or what do you recommend for them?
I can point you in the same direction. There maybe one thing to note is, I'm not sure if you noticed that, so the paper eventually got published in August, and it takes some time to get through the peer review process, and we put it out as a preprint, which we usually don't do, but we wanted to get this message out as soon as possible. And we shared the data before we actually uploaded it to the preprint server with the WHO, and literally a day later, the WHO rewrote their little statements and changed it to, there is no evidence of active virus in human milk. This was back in June. So this has actually made it all the way up to the WHO, changing slightly their messaging. And that's maybe one way to point it to say that WHO has no, or clearly states that there is no evidence for active virus in human milk.
Okay, great. So I'm going to jump back up to the question from Dr. Feldman-Winter. So she asks, is it possible that human milk AB can be anti-idiotypic and provide future protection against COVID-19?
Let me scroll up, I can read this here as well. So at this point, we know there's antibodies in human milk that are directed towards SARS-CoV-2, so the virus that causes COVID-19. There is some work from Rebecca Powell, for example, over in New York that shows that those antibodies are potentially neutralizing. So you can have a bunch of antibodies that they might not do anything because they're not neutralizing, but she shows that these antibodies aren't neutralizing. The question is, how long do these antibodies stay around in mom and then also get handed over with the milk? So I think we have a lot of questions that we need to answer in that space still. But the good news is that there is evidence that we find these antibodies. There is some evidence that they are neutralizing. The question is, how long do they stay around, and do they provide future protection? And that's not even clear in the adult space, right? If you are infected with COVID-19, how long does that actually stay around, that protection? And that makes me worry a little bit when we talk about vaccine development, because that's exactly what that's about, right? If you develop a vaccine, you're prompting an immune response, you're generating antibodies, and you want to have those antibodies stick around, or at least have some memory about this. And if that's not the case, then your vaccine is not particularly useful.
Great. I think there's a question from Ricardo Davanzo. So he says, which would be the mechanism for protection against coronavirus of HMOs according to your preliminary data?
Yeah, very preliminary. We don't have really insights into mechanism at this point, but you saw when I had the schematic up of the virus, all of these spike proteins that you see surround the virus are highly glycosylated. So they have sugar molecules around. It's like a sugar ball almost, if you look at the surface of a virus. And so are epithelial cells. They are coated in sugars, the glycocalyx. So there is a lot of sugar interactions, and human milk oligosaccharides are just that, they're sugars, complex carbohydrates. So the idea could be that there is some interactions not letting the virus into the epithelial cell because you're blocking entry by providing those inhibition of sugar-sugar interactions, so sugar-protein interactions. But we don't have specific data on mechanism.
Okay. Great. Well, I think we're probably going to wrap things up now so that we have time to play all of Dr. Geddes' presentation. Dr. Feldman-Winter just wanted to add, like, the AAP guidance also now is using your research to make sure to promote, safety of breast milk. And slides for these presentations will be available after the presentation.
Well, thanks very much for having me.
Thank you, Lars. It's always wonderful to be able to use your skills, talents, and work and wonderful presentations. So thank you so much.
Yes, it was fascinating.
It's great.
And so for Dr. Geddes' presentation, if you do have questions, because it is not live, if you have questions, you can always type them into the chat box and we'll relay them back to Dr. Geddes and then get back to you with an answer.
Hello, everyone. I'm Professor Donna Geddes, and I'm currently sitting in my office in the University of Western Australia in Australia. And I am very thrilled to be able to present preliminary results from a survey we are currently conducting online, so an anonymous online survey. So because we have very low rates of infection here in Australia, we decided not to collect milk samples from breastfeeding women because we had both ethical problems and the fact that we had low rates, as I mentioned. So we were interested then in the health and well-being of breastfeeding women across Australia and New Zealand during this time. First of all, I'd just like to declare my conflict of interests, which are mainly my funding sources, from the dealer, from our government, which is NHMRC, from Singapore, which is an institute attached to the University of Singapore, and a couple of foundations there that you can see at the bottom. Now, I know we're probably talking to real enthusiasts and supporters of breastfeeding, but the reason we're really doing this research is that we know that human lactation is the foundation of a healthy life. So the programming that begins in conception and pregnancy of our children is extended into the first 2 to 3 years of life and is related to nutrition. So basically, human milk has a role in programming the short and long-term health outcomes of our babies. COVID-19 struck Australia around a similar time, maybe end of February, March to the rest of the world. And we have had quite different experiences, perhaps, if you compare us to both the US and Europe. So what we did was we designed a survey, an actual suite of surveys for the online anonymous survey project. And we recruited specifically women that were breastfeeding a baby under 7 months. And what we're doing is administering those surveys every month for 6 months. So it's actually a longitudinal study. But today you'll see the preliminary results of the first arm of the survey. Now, we just need to bear in mind that there is a lot of recent work that are showing other factors that we haven't considered previously that affect breastfeeding. And that perceived pressure to breastfeed, the guilt of stopping breastfeeding, and not having enough milk perhaps has been a long-term issue for mothers. But coping with the demands of baby, housework, partner, and other children is starting to emerge from these studies. So you can see that there is possibly a link between lockdown and mothers being at home, homeschooling with their children and partners, where breastfeeding may be impacted. We also know that the maternal rating of the importance of breastfeeding is one of the major factors that determines duration, notwithstanding the fact that there are socioeconomic impacts, work, cultural, and more recently, depression, stress, and loneliness. So we know that these factors here are associated with a reduced duration of breastfeeding, hence a possible link with breastfeeding rates during COVID-19. So our initial aim in this study was to determine whether the stresses that women were experiencing during the pandemic, did it affect their breastfeeding and their breastfeeding choices? To do that, we harmonised our surveys with Origins, that you can see here, which is a developmental origins of health and disease cohort where 5,000 families are recruited in pregnancy and followed for the first 5 years of life. So that's situated in a hospital called Joondalup campus up in the northern regions of Perth. So Origins and ourselves are administering a behavioural and demographic questionnaire. So the behavioural questionnaire includes things like how often women left the house, how often they're exercising, how often they're watching the news, and things like that. A perceived stress scale, again, a validated questionnaire. The McMaster Family Assessment Device Hardship Scale. So really that looks at financial hardship, mental health continuum, the perinatal anxiety screening scale, and we've shown that these two are very highly correlated, which is good. And then, so I added an infant sleep questionnaire, the validated one from the literature, and a feeding questionnaire, which was an adaptation of the CDC infant feeding questionnaires to investigate how mothers were deciding what they were going to do. So these three here are in addition to Origins. The harmonisation of these four will allow us to combine and get much greater power to look at the wellbeing of our mothers. We have also administered these questionnaires to a longitudinal observational cohort that we have recruited through our lab. So we recruit the mothers in 36 weeks gestation and we sample milk across the first 12 months of life. So you can see we've got colostrum and monthly samples, and then 9 and 12 months, and we're about to hit some of the 24-month-old babies shortly. We collect a lot of metadata, dietary information and medications and health data, but we also importantly collect milk, maternal faeces, infant oral swabs, infant faeces. We do body compositions on the mothers and the babies, and also measure their growth through normal anthropometrics. So the idea of implementing to the survey into this study is that we can look at differences in the composition of milk in the microbiome. So for example, if mother's nutrition is quality is decreased, are we seeing that being reflected in either the growth of the baby or milk composition? And the same goes for stress factors in the milk, which have shown to be related to milk, to infant growth, as well as their temperament. Unfortunately, we won't present these today, but we are going to look at the more global study first. Just to point out this hardship scale here, the reason I'm doing that is because it features heavily in our results as an impactful part of what's happening in COVID. So the mothers answer yes or no to these following questions, and you can see that they're quite substantial questions in terms of creating quite a lot of stress if you can't pay your bills or your rent or mortgage, or go without meals, or unable to heat or cool your home. Have you pawned something, or sought assistance from a welfare or community organisation? The other part of the survey that we will touch on today, but there is a qualitative aspect to it, and so there are worries and concerns, so we track those across those 6 months that we administer the survey. And then, can you tell us about a challenge you faced in the last 2 weeks? As well as the more positive aspect of what did women find about the COVID pandemic that's making their life easier or actually more enjoyable. So we actually made this available online globally, but really most of our respondents came from Australia and New Zealand here. So we've left the rest of the world out. So there's something like 30 participants from a diverse number of countries. To give you a little bit of a background and where we expected to perhaps see the greatest changes is the difference between what's happened in Western Australia, the rest of Australia and Victoria. So our Victorian colleagues experienced, much like the rest of the states in Australia, an increase in COVID cases around March here. You can see that. And then when restrictions were put in place, we had a delay, schools reopened and there was a slight increase, but you can see that it's very kind of level and low here. And then in June, July, we got a second wave. And it was quite, you can see the difference, it was quite extreme. So currently our Victorian people are still in lockdown with only essential services. No schools are open, no universities are open, and there are curfews for the Victorians. Whereas in Western Australia, we had our increase in COVID cases, the first wave in March. We had quite strict border lockdowns very early. So we locked down the borders to foreigners coming in. So we reduced our transmission from overseas people coming in. And then we actually closed our regional borders quite early as well. So we were unable to travel outside of Perth. So within WA, we were locked down essentially, but we are still, our borders are still closed to the rest of Australia. And you can see that you've got a long period here where we are staying very, very low in terms of COVID cases. And just to tell you again, Jacinda Ahern had a slightly different approach in New Zealand, and she created a bubble concept where she locked down the country very hard, very early on, and you can see the first wave here. And then they've virtually had no cases at all. They've had a small spike for which Auckland is now locked down as they continue to diminish transmission. And she used a bubble concept where people only had certain people allowed contact with them in their bubble. So you can see that the measures have been quite effective over here for the transmission of COVID. So let's look at who responded in this survey. And you can see here we've split this into Western Australia, Victoria, the rest of Australia, and New Zealand. So you can see that most of the responses came from WA, but they were fairly reasonable for the rest of the groups. We've recruited essentially women in their early 30s, the mothers of term babies, so that was something as an inclusion criteria. Our first-time mothers represented anywhere from a third to half of the respondents that you can see here, and they were very highly educated. So you can see that most had a bachelor degree, but then the next steps below that were at least diplomas and what we call a TAFE qualification, so more of a trade kind of education. The babies were around about 3 months on average when the mothers first enrolled in this study, and most of them were married or had partners. So we have a bit of a bias here, but that's usually reflected in these studies that I've been looking at recently as well, where surveys have been done in the UK, for example. So what we found was quite interesting with respect to breastfeeding. You can see that 80% of women, apart from New Zealand, who's had more like 70%, were feeding their own breast milk or expressed breast milk. So they were breastfeeding and expressing. And the ones that were feeding exclusively breastfeeding were also quite high. We didn't see any statistical differences between the regions. And then you see that around about 6 to 10% of women had introduced food to their babies, and also similarly had introduced formula. Now, because we asked about the problems that mothers were experiencing, statistically there was a relationship between those who introduced food and formula that were perceived or had low milk production. So that was perhaps not driven by choice or social determinants, but rather more perceptions around the baby's demeanour and how they were settling after feeds. You can see here that there are a number of concerns that mothers had in lockdown, not let down. And you can see that sore nipples are really top of all of the problems they had. So you've got a quarter to a third of women experiencing this. And then you've got about half of them having nipple damage, although this is greater here in New Zealand. We seem to be experiencing less attachment difficulties, but that's around about 20% across the regions. And the nipple shield use is around about 16 to 15%. And you can see that's very similar to those that are experiencing nipple damage. Blocked ducts feature here, more so in Victoria and New Zealand, and mastitis is quite high, so in the realms of 10 to 15%, with a low supply incidence of around 6 to 12%, which we would expect. Interestingly, oversupply has seemed to become a problem for a number of mothers that we've seen in our lab here as well, and that ranges from 9 to 20%. And then you've got about half of women reporting that they had no difficulties at all. So let's start looking at what is going on with the well-being of our mums and their health. So if we look at their self-reported anxiety, you can see here that Victoria takes the cake. WA follows, we follow slightly more here, but it ranges from 10 to 30%, which we would kind of expect in terms of anxiety. And then we see rates of depression, self-reported depression, around 15 to 10% here. Okay, and what we did also was look at a number of metabolic disorders that are associated with low milk supply. And you can see we have 10% in the realms of quite low, 10% here of PCOS, polycystic ovarian syndrome. We have diabetes, and this was diagnosed before pregnancy, so type 1 or type 2. And then we have fertility issues and thyroid disorders. So the reason we chose those is that the hormones involved in those metabolic disorders are also involved in the breast development and milk synthesis pathways. So what were our mums doing and how were they feeling? So most were employed on maternity leave, and few had their employment impacted, so the mother's employment. However, we do know that there are some worries of whether they would still have their jobs after maternity leave. Our mothers comprised a third to half of them of health professionals or students, and you can see here that we have quite low rates, 30 to 40% of women that are only leaving home 5, 6 or 7 days a week. So they're spending half of their time at home. And same again here, we've got quite low numbers of mothers that are going out and exercising 5 or more times a week. And we have obviously higher rates of those avoiding contact with 65-year-olds and elderly people in Victoria because they're locked down. A lot of them are checking the news daily, but very few are in self-isolation. So if we look at the rates of anxiety in these women, you can see this is minimal. So most mothers have minimal anxiety, so over 40%. The red is the missing data. And you can see here that the mild to moderate ranges from about 13% to 35%. So we've got a large chunk of mothers sitting right in that mild to moderate section. And then we have a smaller number with severe anxiety symptoms, but it's not insignificant. So it's up to around about 10%. If we look at our other scales here, we have again around about 6% of women in the perceived stress scale rating as high, whereas most of our mothers sit in the middle there in a medium stress level, and about a third in the low. Of concern is that, in the mental health continuum, we have about 3% of women languishing. Again, most of them sitting in the moderately mentally healthy, but we have a number that are flourishing as well. So we have that dichotomy going on where some women are doing really well and others are struggling. You can see the financial hardship is not insignificant either. It's around about 20% that are experiencing problems paying their bills. So if we look at the statistics and we factor in hardship and sleep to look at this infant sleep, to look at the levels of anxiety and stress experienced by women, this is linear mixed modelling. Okay, so basically that accounts for what region the mothers were in, the hardship, going out to exercise, feeding frequency, and a number of the infant's sleep variables. And you can see here that hardship really does make a massive impact when we start modelling these outcomes. You will get much more higher levels of anxiety as hardship increases. But interestingly, entwined in this is taking longer to put the baby to sleep also increases the mother's anxiety. Again, you see the same here with the perceived stress scale, where hardship increases stress. And again, taking longer to put the baby to sleep also increases the perceived stress. Even when it comes down to family dynamics, so this is the family influence and how well the mother feels supported by the family, taking on to put the baby to sleep pops up again. What was interesting in the univariate statistics was the very fact that if you were breastfeeding, you had felt better supported by your family. So the very active breastfeeding we know changes the physiology of the mother, and all that oxytocin makes her more calm perhaps and resistant to repetitive tasks, but also the interaction with the family was associated with breastfeeding itself. So we're hoping that when we do the more complex modelling, we'll see more of that, and especially if we include our other cohort. To give you a snapshot of how long it's taking mothers to put their babies to sleep, you can see it's quite a skewed distribution. Some women are taking a very long time. So this is minutes along here. So over an hour, there is a number of women spending that amount of time trying to get their babies to sleep. And you see here that most of this proportion sit in the 30-minute range and a large proportion sitting in the hour range, which suggests that this is intricately entwined into the mother's well-being, that it's something we should be addressing and talking about expectations of biologically normal sleep in babies, particularly when mothers are in lockdown and have a lot of people around as well. Another thing that popped out in the univariate models was if the mothers exercised 5 or more times a day, it was actually protective of the mother's well-being, which is, I guess, no surprise. So what we have is that we have the financial stress being a major factor in causing stress in the mums and well-being, as well as expectations and perceptions around how long it takes the baby to get to sleep. But this is somewhat offset by exercise, and if the mothers can actually leave their homes to get some exercise. I'd like to finish on a more positive note by just letting you know that we've had a preliminary look at the positive question. Can you tell us how lockdown has made any parts of your life easier or more enjoyable? And there are 3 themes that appear to come out: more time with the partner at home, time to connect with family, and reduce pressure to do extra tasks. For example, have visitors and go out. So these are some of the quotes from the mothers. And you can see that more time together as a family due to husband being home usually works away. So we have a big mining contingent where husbands are away for 1 to 2 weeks and then come home for a week and go away again. Less stress about being places on time, having the house clean and tidy for visitors that might drop in. Husband is home working, so he's able to do more of the running round for the older 2 with regards to school and childcare drop-offs while I'm at home with the baby. It took the pressure off to get out of the house. It also made me exercise every day. And this is a really nice one. You know, I have been able to bond with my daughter without having other commitments. So really, to try and summarise what I've told you so far in the first snapshot of this survey is that the pandemic is impacting the well-being of breastfeeding women. So we still have a high incidence of breastfeeding problems, yet we have high levels of breastfeeding. And we need to acknowledge that many of these women are suffering financial hardship, and this is one of the drivers of their stress and anxiety. So it may be that they were continuing to breastfeed because it's an economic choice as well. We need to ensure that we ask about infant sleep and educate around those reasonable expectations, and remember that exercise is protective for the mother. And we also have a protective effect of breastfeeding, of course, that we haven't quite finished analysing. So with that, I would like to just acknowledge the people on this project, particularly Jackie McEachran, who has organised REDCap and all of the surveys and is monitoring those, Alethea Ray, a biostatistician extraordinaire, and Vanessa Sakalides, who is locked down in Switzerland, or not so locked down now, who's a biostatistician in the making, as well as Sharon Perella, who is our postdoc neonatal nurse, lactation consultant, all things clinical, to help with the interpretation of the results. You can see my research team here in the middle of COVID having a lab meeting, and of course they all contribute in one way or another. So thank you for your time. I'm happy to answer any questions virtually, and stay safe and take care.
Well, we'll thank Dr. Geddes for her presentation. And like she was saying, if you do have questions, please enter them in the chat and we will relay them to Dr. Geddes and she will provide an answer. So I think we're at the end of the hour. So we'll wrap things up. We just want to thank you for attending, for our attendees, and then also thank our presenters again for these really engaging and interesting presentations. And we look forward to having you join us on our next webinar, again, about Baby Friendly USA and their kind of COVID-19 updates. And that's going to be on October 14th.
Thanks, everybody. Thanks for attending. Take care and goodbye till next time. Thanks, Laura, for presenting.
Thanks.